Dear colleagues, it's an honor and a pleasure to present the integrating of immune therapy in early-stage breast cancer disease. And we are focusing today on triple-negative breast cancer. My name is Sherko Kümmel. I'm the director of the breast unit at the Women's Cancer Center at the clinics Essen-Mitte. This is located at the western part of Germany. To summarize, stage 2 and 3 early triple-negative breast cancer disease patients have always the same kind of therapy. They have a neoadjuvant strategy beginning at that situation with taxanes, carboplatin plus pembrolizumab, followed by anthracycline, cyclophosphamide, again together with pembrolizumab. Afterwards, the surgery, and after the surgery, according to the aspect of the tumor volume that you have, according a PCR, pathological complete remission, or a non-pathological complete non-PCR. For all these patients, the standard of care is to treat them again with 9 cycles of pembrolizumab. We see just small differences between the guidelines, the ESMO living guidelines and the ZN's guidelines. We actually don't have a fixed standard of care for stage 1 early triple-negative disease patients. You have the smaller patients where the ESMO guidelines said maybe if it's really small tumors, maybe detected in screening or maybe in ultrasound situations, or if you have other lesions and there was a small lesions less than 5 millimeters, you have to consider no systemic therapy maybe for these patients. If it's larger than 5 millimeters, PD-1B, or larger, it's centimeter, of course, in both guidelines, a chemotherapy is recommended without immunotherapy, and that situations mostly used as dose-dense anthracyclines followed by paclitaxel or TC. According, we don't have fixed standard of care for these patients using the most scheduling of anthracycline and taxanes for these patients in the neoadjuvant strategy. The next difference is maybe to say do it neoadjuvant or preoperative means or adjuvant. There we have no standard of care too. Both options are possible in that situation. My personal situations is if the tumor is more than 1 centimeter, I prefer the neoadjuvant strategy to treat the patients with these kinds of conventional chemotherapy. The KEYNOTE-522 trial started with a neoadjuvant proportion of therapy. This was using in an inverse sequencing paclitaxel, platin plus pembrolizumab versus placebo, and followed by anthracycline, cyclophosphamide plus minus pembrolizumab or placebo in that situations to investigate it. Afterwards, after finishing on conclusion of the neoadjuvant part, there was the surgery, and then giving again an adjuvant monotherapy of pembrolizumab for all patients or placebo-controlled. The standard of care has the carboplatin, and that means this is the highest standard of care that we have. We saw at first an over 10% better PCR rate using pembrolizumab for patients in a neoadjuvant strategy, additionally to conventional chemotherapy. The next situations, everyone was waiting on that, it was the situations, the first 3-year event-free survival rate, and there we see that after maybe 18 months and after with 36 months and all the months where we have the analysis, we saw always the same results, that we have a significant better event-free survival if the patients get additionally to the neoadjuvant strategy of conventional chemotherapy, pembrolizumab, and additionally in the adjuvant situations. The first announcement of the 18 months event-free survival was 91.3 versus 85.3 with a hazard ratio of 0.63. And looking more at the recent data show that the Miami breast cancer meeting, the final OS and subgroup data, we saw interestingly, if you're looking at the data 3, 4, and 5 years, you have always nearly the same hazard ratio of benefit of pembrolizumab. After stopping of 9 cycles in the adjuvant situations, you see with this strategy of neoadjuvant and adjuvant using immunotherapy together with conventional chemotherapy, you cure more patients because after 3, 4, 5 years, you have the separation of the curves and this survival benefit for these patients. If you're looking more deeply on the RCB scoring, this is translation, how is the pathological or non-pathological complete remission rate in that situation. You see if the patient has an RCB 0, that means pathological complete response, you see again with an hazard ratio of 0.66, the benefit with using pembrolizumab. I think if you summarize this, these are all the data led to the approval of pembrolizumab and the neoadjuvant and adjuvant strategy. First of all, there's the questions, how is it with biomarkers? And we can summarize this for the early breast cancer disease situations of triple-negative patients. We have no validated biomarker to reliably predict which patients will benefit most from pembrolizumab. And this is really important because this is different to the locally advanced or metastatic disease situation. We don't have stage 1 triple-negative disease complete standard of care. Most of our colleagues using anthracyclines and taxanes, maybe dose-dense as a backbone, some colleagues using taxane-free regimens. In my personal opinion, we have to use platinum because in all trials we saw that the combination of taxanes and platinum has a survival impact of better survival for the patient. So I think a next strategy could be 12 weeks of carboplatin and taxane. There are several trials ongoing. Some trials are looking at de-escalations, no chemotherapy if the TILs are quite high. We started a trial giving sacituzumab plus minus pembrolizumab for stage 1 disease patients. And all of us are maybe awaiting on the results of these trials, getting maybe the next step further for stage 1 disease patients, maybe creating a new standard how to treat them. The other questions is always, if we don't do the neoadjuvant situations, if we do the chemotherapy and the immunotherapy adjuvant, we can summarize this with different kinds of trials. I think they are not successful. The only part, or pure part of adjuvant immunotherapy is not successful for our patients. We have the Alexandra and Passion trials for atezolizumab with no benefit. We have the ABREF trial. If you have a pure adjuvant situations with these patients, there was no benefit. If the patients treated in the ABREF trial neoadjuvant with only chemotherapy and getting avelumab and the adjuvant situations, there was no, for primary endpoint, no disease-free survival benefit. The OS in the later stage was improved. Can we change the anthracyclines maybe to ADCs? There are different trials are running. There's a trial running with sacituzumab TMT in the future. There's a trial running with datopotamab. The Tropion-04 trial is running with the questions, can we replace the complete conventional chemotherapy with pembrolizumab to an ADC plus an immune therapy, again, for these patients? I think these are interesting questions to look at that. In the future, there are some other trials are running for de-escalating and escalating questions. De-escalating, can we stop after 12 cycles of carboplatin and taxanes and pembrolizumab the chemotherapy if we have a clinically complete remission and after surgery pathological complete remission, or if we have non-clinically complete remission after this starting sequencing of taxanes and platin and pembrolizumab, and then maybe to randomize ADCs, in this maybe sacituzumab versus anthracyclines. I think these are strategies where we more modeling and get more and more answers, maybe how to preserve patients for more chemotherapy, how we preserve for maybe toxicity from anthracyclines, or maybe in this kind of escalation, how we do more effective the next step further for the neoadjuvant strategy. There are different trials ongoing in that situation. And then we're always coming to the post-neoadjuvant strategy. I think this is an unmet need. I think mostly for the non-PCR patients. And we have different trials ongoing for that one. And first of all, we have the Tropion trial, again, datopotamab plus durvalumab questions. We have the Zaskia trial is one of the first trials announcing its data. If we using an ADC in non-PCR situations, is there an additional benefit? As we know, and I showed you before, that the non-PCR patients, this is the patient with an unmet need because the survival, I think we have to develop it further and that we have maybe in the future better survival for these patients. The next one, there's an Ascent of 5 trials running, again with sacituzumab in that situations. In these trials, we assume together to use capecitabine and maybe the immunotherapy with durvalumab or immunotherapy with pembrolizumab in the different trials, together with capecitabine, because we think that the combination of capecitabine and pembrolizumab is the most effective combination without any phase 3 data to bring this as a standard of care, but to see that you have the highest standard of care in that situations if you tested if an ADC, an antibody drug conjugate like sacituzumab, datopotamab, or in future sacituzumab TMT would be replace the capecitabine situations to have more efficacy. I think all these trials are ongoing and looking for that one. I think this is, we have the Oxford trials, only phase 2 trial with some patients that we see probably the situations of non-PCR patients and combination of capecitabine and pembrolizumab is more effective. And the summary of maybe potentially approval trials, I think the Tropion Breast 03 trial, the Trophus trial with sacituzumab TNT, and the Ascent of 5 trial with sacituzumab. And again, as I mentioned, versus a high standard of care arm as a control arm. I think these are the data where we are waiting and where we are thinking that we have a further development to treat and to cure more patients with early stage triple-negative breast cancer disease. Many thanks for your attention.
Welcome. My name is Rebecca Dent. I'm a medical oncologist at the National Cancer Center Singapore, and I'm delighted today to talk you through personalizing immunotherapy in metastatic triple-negative breast cancer. So looking at the ESMO, Pan-Asian, and NCCN guidelines overview, across all of these guidelines, we usually position immune checkpoint inhibition and chemotherapy in this first-line setting for those patients that are PD-L1 positive defined by CPS score greater than or equal to 10, or as we know, SP142 positivity greater than 1%, but regardless of BRCA status. And so what this means is that we really position PARP inhibition in the second line setting if they are PD-L1 positive, and then we position the ADCs following progression on immune checkpoint inhibition and chemotherapy, or after PARP inhibition in the case of patients that are germline BRCA1 or 2 carriers. Now, one of the new players is looking at dostarlimab, and this is in patients that are deficient MMR, and this has been shown actually across many different tumor types. So it's not just breast cancer, and then also looking at patients who are MSI high or TMB high. Now, this is very rare in breast cancer, but it's important to be aware of. And then I think another point worth noting is that, once patients have progressed, let's say on immunotherapy and chemotherapy first line or PARP inhibition, we now have a number of new players. So we have a number of different antibody drug conjugates. We have sacituzumab, we have TDXD, a number of other compounds that are being evaluated, that not to be forgotten in the metastatic triple negative setting. The other thing that's really important to mention is looking at the disease-free interval from the time of their adjuvant therapy. So in the studies looking at pembrolizumab plus chemotherapy, it included patients that are PD-L1 positive, CPS score greater than or equal to 10%, when the DFI was greater than or equal to 6 months. And in the case of the atezolizumab trials in combination with chemo, if they were PD-L1 positive, disease-free interval greater than or equal to 12 months. So I'm going to take you through first looking at the Keynote 355 data. So as we know, Keynote 355 is looking at patients who received pembrolizumab in combination with chemo or chemotherapy alone. And what you can see is an improvement from 16.1 to 23.0 months with the addition of pembrolizumab in those patients that are PD-L1 positive, CPS scores greater than or equal to 10, hazard ratio of 0.7. Now, the important thing I think about this trial is that the backbone of chemo included solvent-based paclitaxel, nab-paclitaxel, or carbogem. And as we know, carbogem, there's no hair loss and is a nice option for patients in this first-line setting. Now, next compound is atezolizumab, which currently is not approved in the US, but is used in Europe and in some parts of Asia. The landmark study was looking at the Impassion 130 study, which is looking at nab-paclitaxel. There we saw an improvement in overall survival, but in Impassion 131 and 132, so looking at solvent-based paclitaxel, we did not see an improvement in PFS and OS. And in Impassion 132, where the disease-free interval was less than 12 months, we did not see an improvement in outcomes with atezolizumab. And finally, tirpalimab, looking at the Torchlight study, again, looking at PD-1 inhibition in combination with chemotherapy versus chemotherapy alone, we see a consistent improvement in progression-free survival in favor of tirpalimab. So first, a lot of it just depends on where you live in the world. So if you're going to live in Europe, atezolizumab plus and pembrolizumab are available, and certainly in Asia, you have access to both. If you're living in China, you have access to tirpalimab, but if you're living in the US, you only have access usually to pembrolizumab. You may use clinical trial data and real-world evidence. Now, for me, a lot of it has to do with the chemotherapy backbone, and certainly with the Keynote 355, we have the option of giving solvent-based, nab-paclitaxel, or carbogem, as I mentioned before. Now, there may be some patient or tumor factors that we use. So, if you've used immune checkpoint inhibition in the curative setting, are you then going to use it in the metastatic setting? And this is certainly the area of interest for a lot of the ongoing clinical trials. So first of all, our pathologist has to be very familiar that if we're looking at giving pembrolizumab, the biomarker that we're going to use is looking at the CPS score and is looking at a greater than or equal to 10 PD-L1 positive score. Now, if we're looking at giving atezolizumab, the EMA has approved this for PD-L1 positive greater than or equal to 1%, but this is using the SP142 assay. And then, as I mentioned, MSA high, deficient MMR, and TMB high testing is now included in the NCCN guidelines as well as the ESMO guidelines. And I think certainly for breast, we're not sure what the cutoff for TMB should be, but right now it appears greater than 10. And then another very common question are what biopsy should we do? So the first thing is I always try to get a biopsy in that metastatic setting. And that's because you really do want to repeat ER, PR, and HER2, especially in triple negative breast cancer. We also want to often get next gen sequencing. As we know, across many of the different tumor types, we may find biomarkers that guide therapy that are important or eligible for certain clinical trials. Now, if we're looking at PD-L1 testing, I always say that the most optimal areas to test are not in the liver. So I usually try to do lymph node or skin or potentially lung, but ideally lymph node. And here the studies have suggested that those were the optimal areas to biopsy, so not liver. Now, the other thing I get asked frequently is, what about using the archival specimen? So, as I said, I'd prefer to have a fresh biopsy because that's what we always do. We need to confirm that this is in fact breast cancer that has spread and that get more up-to-date information on the tumor that makes the patient eligible for trials. But if I don't have access, I can go back to the primary. And if the patient is PD-L1 in the primary, certainly in a lot of the impassioned trials that suggest that the hazard ratio is still significant in terms of benefit from immune checkpoint inhibition. It's just that the delta, the absolute improvement in terms of outcomes in the metastatic setting of IO is actually better if the more recent specimen is also positive. But if you have an adjuvant specimen, certainly you can use that as well. And then finally, how do we determine who's going to benefit from immunotherapy? In my own experience, PD-L1 positivity is a very crude biomarker, meaning you might see in different biopsies potentially different levels of, let's say, CPS score measures, and some it might be 6 and some it might be 12. And so that sort of encourages us to do more biopsies. But also it tells us that, over time, we may identify a better biopsy. So what that means is that there probably is a broader group of patients that likely will benefit from this combination immune checkpoint inhibitor and chemo approach. But it also means that not all patients respond. And in fact, some patients may benefit from a combination IO approach. And we'll talk about some of these new therapies on the horizon. So there was exciting data coming out very soon, in fact, looking at some of these new approaches. So the first one is looking at the ADC plus immunotherapy combination. And we know is that this can be synergistic. And so the application of ADCs can upregulate STING and have this increased benefit from immune checkpoint inhibition. So the first study is looking at the ASCENT-04 study, which is a phase 3 study that suggests there'll be improvements in progression-free survival when we combined the antibody drug conjugate sacituzumab plus pembrolizumab in this first-line metastatic triple-negative setting, looking at patients that are PD-L1 CPS score greater than 10 positive versus chemotherapy plus pembro alone. The second study, looking at, again, ADC sacituzumab plus atezolizumab, we've seen some benefits in the Morpheus pan-breast cancer and interim analysis. Third, looking at sacituzumab plus toripalimab. Here, looking at there's an ongoing phase 2 study that's recruiting, and again, looking at this ADC IO combination. Similarly, there's some data that were published in the Begonia study looking at Dato-DXd plus Durva, and these are very impressive waterfall plots looking at quite a deep response, so 80% response rate, PFS of 14 months. And what was interesting about this combination is that the results seem to be irregardless of the PD-L1 status or true expression, again, highlighting this potential synergy. And finally, the bispecific antibodies, which I am most excited about. So looking at combinations of bispecifics with antibody drug conjugates. And this one in particular, looking at BNT327, which is looking at a bispecific of VEGF and PD-L1 inhibition in combination with BNT325, which is an anti-TROP2 ADC. And so again, looking at these different agents that target the microenvironment, you may see augmented response. And so we saw some early data from this looking from Erica Hamilton, and we look forward to opening phase 3 studies in patients with triple negative. But we've already seen some really impressive improvements that have been published already in non-small cell lung cancer. And finally, looking at other combinations, again, looking at bispecific and chemotherapy, look out for ongoing trials recruiting patients. And this is really promising for our patients with metastatic triple negative, but also in the earlier setting, trying to incorporate some of these combinations in the early breast cancer setting. Thank you very much for your attention today.
I'm Peter Schmid. I'm a medical oncologist. I work at Barts Hospital in London. I'm with you today to talk about how we maximize immune therapy benefit in patients with triple negative breast cancer. Immune therapy is a very different concept of therapy to our standard chemotherapies. With chemotherapies, we have a very well-established safety profile for most drugs. We have a number of side effects that occur in most patients, if you think about hair loss or nausea, and where we know very well at what time point which side effects are expected. Immune therapy is very different. The majority of patients have relatively few side effects, have fewer of the classic chemotherapy side effects. But at the same time, what we sometimes see is that we activate the immune system too much, and patients have autoimmune type reactions. And in theory, any part of the body can be affected by an immune-related adverse event or side effects. Now, these side effects can sometimes be similar to side effects we see with chemotherapy. It can involve any possible organ, and it can also occur at any point in time in a not always predictable manner. We even see sometimes immune-mediated side effects a few weeks or months after patients may have finished their immune therapy. Now, some of those side effects are more common, other side effects are less common. The most common side effects we see with immune checkpoint inhibitors in breast cancer therapy are what I would call endocrine side effects. And within these endocrine side effects, most commonly changes in the thyroid function. overfunction, or more commonly an underfunction of the thyroid gland. But of course, it can also affect other endocrine systems, for example, an adrenal insufficiency. Other side effects are much rarer, but we see skin reactions. We see, for example, diarrhea as a side effect of an inflammation of the bowel. We can see pneumonitis. We can see changes in liver function tests. But in theory, any part of the body could be affected. What is really important for us that we are aware of these possible different side effects, that we monitor patients early on, and that we react to the side effects as soon as they occur. Early detection and early intervention is critical when it comes to immune-mediated side effects. And obviously that involves every member of the team. The better the team functions, the safer the patient will be, the better the treatment tolerability is. There are a few steps we put in routinely, for example, blood tests, checking liver enzymes, checking the kidney function, checking the thyroid function, but also baseline cortisol in slightly wider intervals. We also have to work very closely with the patient to inform them what to look out for and to share with us as a managing team as early as possible if any possible side effects occur. The patient role is here really critical, because with immune-mediated side effects, they can be mild one day, but can then suddenly get more severe if they're not managed very well. It's also important that the team is aware of this. We had to change in our hospitals, I'm sure that's the same, or everywhere, that teams learn, for example, people on the triage line, if patients phone, learn to see whether patients are immune therapy or not. And we more often have to review those patients at an earlier stage to ensure that the symptom a patient is reporting may not be down to an immune-related adverse event. Because with immune-related adverse events, we have an antidote. We have a treatment with steroids that can improve most of those side effects relatively quickly. And it is critical that these steps are started as early as possible. So therefore, in order to give immune therapy safely, we have to function well as a team, inform the patient what to look out for, inform every team member to be alert to possible immune-mediated side effects, do routine monitoring of some of the more predictable events, especially blood-based events, and intervene very early on if immune-mediated adverse events occur. So one of the examples we often use in clinic is change in the thyroid function, whether it's an overfunction or an underfunction of the thyroid gland. And again, when we started working with immune checkpoint inhibitors, we would routinely phone up the endocrinologist and ask for advice of that situation. But ultimately, it comes down to some very basic principles. And these days, we are confident, for example, to patients who have an overfunction of the thyroid, we usually know this is self-regulating, will last for a short period of time. We manage some of the associated symptoms, for example, with a beta blocker if patients are tachycardic or have palpitations, but ultimately monitor those patients very carefully, because they will develop an underfunction of the thyroid gland. If they have an underfunction of the thyroid gland, again, it is not rocket science. These patients should be started on replacement therapy with L-thyroxine, and we usually as oncologists are able to get that process started rather than having patients to wait for a review of an endocrinologist. In the majority of patients, immune-related adverse events are relatively mild, but of course, as with any treatment we have for cancer, sometimes the side effects can be more severe. The key factor, as I said before, is to detect, to recognize those side effects as early as possible, and to start at any side effect management as early as possible. And in order to avoid that those side effects get to grade 3 or grade 4, usually if patients have higher grade toxicity, we have to at least hold the treatment. But with some of those grade 3 or grade 4 events, we may have to permanently continue immune therapy. What is really important is that we start patients early on steroids if they have immune-related adverse events, and that often allows us to re-challenge patients earlier. For example, if patients have a short time grade 2 pneumonitis, inflammation of the lungs, if they're started on steroids, if the symptoms and CT changes resolve relatively quickly, patients often can be re-challenged successfully with the immune checkpoint inhibitor. On the other hand, if we wait longer, and for example, for liver function test elevations, they go to grade 3, it is very difficult to justify re-challenging patients, whereas if it had been a short-term grade 2 elevation of liver function test, we could restart patients on immune therapy once the liver function tests have normalized. So essentially, key is, as we said before, be alert, recognize immune therapy side effects early on. When they get to grade 2 or higher, we would usually hold the treatment with a few exceptions. We would also relatively early start on oral steroids, and often when it gets to grade 3 side effects, switch those steroids to intravenous steroids. If there's no improvement of the immune-related adverse events, we may have to bring in other treatments to enhance the immune suppression, to downregulate the immune-mediated adverse events. We will then have to see and take balance of how the patient benefited from therapy. So what's the treatment benefit and what is the possible risk if we want to continue patients on therapy? And depending on the type of side effects, patients can often successfully restart it on immune checkpoint inhibitors. As for all aspects of oncology care, but I think particularly for immune therapy, multidisciplinary working is critical. It is, no one can look after patients on their own and give them an optimal service. Oncologists, of course, are at the core of the multidisciplinary team. And again, that's really important that as an oncologist, we have to be the ones to get informed first if there are possible side effects associated with immune therapy, and we have to initiate any treatments as early as possible. One of the caveats I would really highlight is we often talk about multidisciplinary care, and that often some people interpret it in a way that if there's, for example, pneumonitis, I can't start the patient on steroids until they have been seen by a chest physician. I would strongly advise against this unless you have 24-hour access to specialists. The earlier you start steroid medication, the better the outcome of patients will be, the quicker the symptoms improve. So the oncologist really has to be in the driving seat and has to make that decision whether or not to modify the treatment, whether or not to start patients on immune suppression with steroids or going beyond. Of course, the oncology team goes beyond the oncologist. This refers to all the nurses involved. This refers to the triage team often. And if patients, for example, call the hotline talking about a rash, it may be much more relevant if patients are on immune therapy to see those patients quickly than it is sometimes with standard chemotherapy. In some situations, and that is not very common, we need to get help from other specialists. And from my experience, this is usually if patients have grade 3 or higher immune-related adverse events that seem to be refractory or not responding terribly well to steroids. So what I often say to patients or my team is, steroids we handle ourselves, but when we have to go beyond steroids, I would like to get other specialists in as quickly as possible. And of course, there are very rare side effects, for example, renal side effects, cardiovascular side effects, or neurological side effects. We don't see them every day. And I think with those side effects, we tend to get specialists involved a little bit earlier than we would do with the more common side effects. Ultimately, keeping patients safe on immune therapy, making their treatment effective, requires multidisciplinary input, and that involves all members of the core oncology team, but also of the wider specialist team.